frequently asked questions about management of diabetes during Ramadan. What are the risks for people with diabetes? WHO participate in Ramadan. The principal risks for people with diabetes who participate in Ramadan are hyperglycemia, DKA, dehydration and thrombosis. What are the three categories of risks for patients WHO participate in Ramadan? Category 1. Very high risk. One or more of the following. Severe hyperglycemia within the 3 months prior to Ramadan. Unexplained DKA within the 3 months prior to Ramadan. Hyperosmolar hyperglycemic coma within the 3 months prior to Ramadan. History of recurrent hyperglycemia. History of hyperglycemia unawareness. Poorly controlled T1DM. Acute illness. Pregnancy in pre-existing diabetes, or GDM treated with insulin or SUS. Chronic dialysis or CKD stage 4 and 5. Advanced macrovascular complications. Old age with ill health. Category 2. High risk. One or more of the following. T2DM with sustained poor glycemic control. Well-controlled T1DM. Well-controlled T2DM on MDI or mixed insulin. Pregnant T2DM or GDM controlled by diet only or metformin. CKD stage 3. Stable macrovascular complications. Patients with comorbid conditions that present additional risk factors. People with diabetes performing intense physical labor. Treatment with drugs that may affect cognitive function. Category 3, moderate or low risk. Well-controlled T2DM treated with one or more of the following. Lifestyle therapy. Metformin. Acarbose. Thiazolidinidionase. Second-generation SUS. Incretin-based therapy, DPP4 inhibitors or GLP-1 SGLT2 inhibitors. Basal insulin. Which categories of patients should not fast? Patients who are in the two highest categories of risk should not fast. What is the pre-Ramadan assessment? All patients with diabetes who wish to fast during Ramadan should prepare by undergoing a medical assessment and engaging in a structured education program to undertake the fast as safely as possible. This assessment should take place 1 to 2 months before Ramadan. Specific attention should be devoted to patients' overall well-being and to the control of their glycemia, blood pressure, and lipids. Appropriate blood studies should be ordered and evaluated. Specific medical advice must be provided to individual patients concerning the potential risks they must accept if they decide to fast. During this assessment, necessary changes in diet or medication regimen should be made so that the patient initiates fasting while on a stable and effective program. This assessment should also extend to those who do not wish to fast because they often are exposed to the risk of hypo and hyperglycemia during Ramadan as a reflection of social habits encountered during the month. What are the key components of pre-Ramadan education? The key components are risk quantification, blood glucose monitoring, nutritional advice, exercise advice, medication adjustments and knowing when to break the fast to minimize acute complications. Perhaps the most crucial issue is the realization that care must be highly individualized and that the management plan will differ for each specific patient. What is the advice for blood glucose monitoring? It is essential that patients have the means to monitor their blood glucose levels multiple times daily. This is especially critical in patients with type 1 diabetes and in patients with type 2 diabetes who require insulin. What is the advice for exercise? Normal levels of physical activity may be maintained. However, excessive physical activity may lead to a higher risk of hypoglycemia and should be avoided, particularly during the few hours before the sunset meal. Quite commonly, multiple prayers are performed after the sunset meal. This generally involves repeated cycles of rising, kneeling, and bowing, and should be considered a part of the daily exercise program. In some patients with poorly controlled type 1 diabetes, exercise may lead to severe hyperglycemia. What is the advice for nutrition? During Ramadan there is a major change in the dietary pattern compared with other times of the year. Most health problems are likely to arise from inappropriate diet or as a consequence of overeating and insufficient sleep. Therefore, the diet during Ramadan for people with diabetes should not differ significantly from a healthy and balanced diet. The nutritional advice should be tailored to their special needs and medical problems. It should aim at maintaining a constant body mass. In most studies, 50 to 60% of individuals who fast maintain their body weight during the month, while 20 to 25% either gain or lose weight. The common practice of ingesting large amounts of foods rich in carbohydrates and fats, especially at the sunset meal, should be avoided. Because of the delay in digestion and absorption, ingestion of foods containing complex carbohydrates, slow digesting foods, may be advisable at the pre-dawn meal, which should be eaten as late as possible before the start of the daily fast. It is also recommended that fluid intake be increased during non-fasting hours. What is the advice regarding breaking fast? All patients should understand that they must always and immediately end their fast if symptoms of hyperglycemia occurs or if blood glucose reaches less than 3.9. The fast should be broken if blood glucose exceeds 16.7. Patients should avoid fasting on sick days. What is the pharmacological management for metformin and acarbose? Severe hyperglycemia in non-fasting patients receiving metformin and acarbose is rare. No dose modification is needed, but timings should be changed depending on the frequency of dose. For metformin, immediate release, OD, take at iftar, BID, take at iftar and sahur, TID, morning dose at sahur, combine afternoon and evening dose at iftar. Prolonged release, take at iftar. No adjustment to TZD medication is needed during Ramadan and doses can be taken with iftar or sahur. What is the pharmacological management for sulfonylureas? Switch to newer SU, glycoside, glympyride, where possible, glibenclamide should be avoided. OD, take at iftar. Dose may be reduced in pints with good glycemic control. BID, if the dose remains unchanged. Sahur dose may be reduced in pints with good glycemic control. What is the pharmacological management for SGLT2 inhibitors? SGLT2 inhibitors have demonstrated effective improvements in glycemic control and weight loss, and are associated with a low risk of hyperglycemia. Because of this, these drugs could be a safe treatment option for patients with T2DM during Ramadan. However, certain safety concerns have been raised, such as an increase in dehydration or postural hypertension, as well as the risk of ketoacidosis. Patients deemed more at risk of complications, such as the elderly, patients with renal impairment, hypertensive individuals or those taking diuretics, should not be treated with SGLT2 inhibitors. Most physicians agreed that SGLT2 inhibitors should be taken with iftar, and the importance of taking on extra fluids during the evening after a fast was highlighted. Due to the low risk of hyperglycemia with SGLT2 inhibitors, no dose adjustment is required. What is the pharmacological management for insulin? Problems facing patients with type 2 diabetes who administer insulin are similar to those with type 1 diabetes, except that the incidence of hyperglycemia is less. Again, the aim is to maintain necessary levels of basal insulin to prevent fasting hyperglycemia. An effective strategy would be judicious use of intermediate or long-acting insulin preparations plus a short-acting insulin administered before meals. Although hyperglycemia tends to be less frequent, it is still a risk, especially in patients who have required insulin therapy for a number of years or in whom insulin deficiency predominates in the pathophysiology. Very elderly patients with type 2 diabetes may be at especially high risk. Using one injection of a long-acting or intermediate-acting insulin can provide adequate coverage in some patients as long as the dosage is appropriately individualized. However, most patients will require rapid or short-acting insulin administered in combination with the basal insulin at meals, particularly at the evening meal, which typically contains a larger caloric load.
Audio Jungle. Audio Jungle.